Again, while Sonia's fixing that, I was relieved that Esther didn't have an introduction as she did for Dr. Blue. And then I remembered what happened 12 hours into our sailing trip off the west coast of France. With the advantage is you can stop a limousine and get out, but on Esther's sailing boat, there's no escape.
It's coming time, so.
Thank you. I'm sure it's my time. Okay. So this is a project I'm quite excited about, not least because hopefully it will keep me employed from 2017 onwards. And yeah, it's the origins of this collaborative, if I go back into the history of it a little bit, were really a series of attempts, which I must give credit to Esther for, blood, sweat, and no doubt some tears, in trying to get funding for a very large-scale biorepository type study based around the infrastructure of the CFS-ME National Outcomes Database. In particular, things like Janine, which was, we tried to get funding for a genome-wide association study, which was actually piloted using saliva samples from patients whose data were stored in the National Outcomes Database. And as you can see, we had the numbers there. We had sort of over 10,000 sort of patient data for over 10,000 patients in the database. But funding for those things didn't actually come off. We also made attempts looking at funding that was based around stratified medicine. So acknowledging, this thing that we know in CFS-ME, that there's heterogeneity. And this was an attempt at sort of an international collaboration. So we looked around the world and found people who were doing studies that would sort of fit within the remit of a sort of international stratified medicine collaborative. But these didn't happen, and so we then spent some time in the sort of desert of not having funding. And the feedback that often came back was something of a sort of chicken and egg situation. So we're saying we need to investigate this disease about which there are so many sort of unknowns. And the answer comes back that, in a sense, you don't know enough about it to sort of characterise it, to define your patient groups, and that you don't have sufficiently detailed sort of hypotheses. So, sort of at this point, I was thinking we needed a sort of Moses-like figure to lead us in the desert. And we actually ended up with three. So Esther and Peter White and Andrew Lloyd from Australia, who I think had various sort of backroom meetings and come up with this idea that maybe if we go back to the beginning, so what do we know? And as has been said in several presentations, and we know far more than anecdotally that an infection is often a trigger for CFS-ME. And if we looked at post-infectious fatigue, we start chronologically with the triggering event, but we also have a more homogeneous patient group. For those of you worried that a Rumsfeld score is yet another patient-reported outcome measure, that's more to do with the fact that as much as I sort of wince at using a Donald Rumsfeld quote, as I'm sure you know, he talked about known unknowns and unknown unknowns. And we thought that with looking at post-infectious fatigue that we have, that there are maybe fewer unknown unknowns, and maybe there are more known unknowns, because we're starting off with an event that we can characterise quite well. And we have prospective data, so we have sort of multiple time points at which we can collect data. And there's a very strong precedent for this. So, for example, in HIV research, there are international collaboratives where where data from multiple cohorts have been sort of brought together. And this greatly increases your statistical power to detect differences and effects. And it also meant that we had an underlying hypothesis. So hopefully this would be more appealing to funders. Okay. So obviously the sort of hypothesis in a nutshell is that CFS has been triggered by an infectious event, so an acute infection. And given the unknowns in CFS, this is quite a sort of key, as I say, waypoint, a starting point for us to do some causal, so etiological epidemiology. And by pooling data and samples, so a lot of these cohorts have collected blood, they've collected biological samples that are frozen in various centres around the world, that if we pool all of this, we'll have much greater power to undertake the epidemiological investigations. So we had a meeting in June this year, and we had Andrew Lloyd from Australia, we had Peter White, we had Ben Katz from the US, we had Norwegian and Dutch collaborators. So just as a starting point, we had these people who've been principal investigators of cohorts. Some of them were historical, some of them are ongoing or haven't even yet started. And so our underlying hypothesis is that the infection causes this acute sickness response, and that then in a proportion of people, there's either a sort of aberrant response or there's some kind of maladaptive response, which leads then to long-term symptoms, including CFS. But we wanted to keep the remit slightly broader, so that's why we're talking about post-infection fatigue, because we know that other long-term conditions, for example, irritable bowel syndrome, can also be triggered by infectious events. But broadly, that the focus will be on fatigue and then implicitly CFSME. Okay, so these are the initial 10 cohorts. It's not carved in stone, so if there's anyone out there who has a cohort which isn't on this list, then please do talk to me afterwards. So we have the sort of historic cohorts like the Bart's infectious mononucleosis cohort, but they still have samples frozen which could potentially be used. We have the two Australian cohorts. We have Dubbo, which then led to the Sydney infectious outcome study. And Dubbo is very important in showing that a range of pathogens could trigger prolonged fatigue in a proportion of people. And that it was more the characteristics of that acute sickness which then predicted the risk of long-term fatigue. And then we have quite excitingly some new cohorts. There's a very large study led by Ben Katz in the US, where they're going to recruit freshman college students, around 6,000, and then follow them through their years of college. And we know that a proportion of them will come down with glandular fever, and we know that a proportion, probably around 10%, will then develop long-term fatigue. And there's another, the SIBA study is similar, that's in Norway. Okay. We have, I think, Eva's here somewhere from Norway, will tell us more about the Bergen giardiasis outbreak cohort. The Q-Quest studies, that's a Q fever outbreak in the Netherlands, which has been followed up now for quite a long time. Given that this is the clinical trials, there are actually a couple of clinical trials nested within these cohorts. So the Q fever chronic fatigue, there's going to be an RCT of doxycycline amongst people who are still fatigued after this Q fever outbreak that was in, I think, 2004. And also the Norwegian SIBA study, there will also be a small trial of a sort of early intervention to prevent CFS in adolescents who have infectious mononucleosis. So towards the end of our meeting, we sat down and thought of what the main research questions need to be. And although we have this sort of known of the triggering event, we can characterise that quite well. Thereafter, it's more the sort of things we know that we don't know. I'd like to emphasise where I put biopsychosocial. Within those first three letters, the bio, that pretty much encompasses, you know, everything that's been talked about these yesterday and today. So that's sort of immunological markers, inflammation, just about everything that we can think of. So in a sense that the bio in biosocial is probably the larger part of the sort of etiological factors that we'll be looking at. So yeah, as I say, those are the first 10 cohorts, and everyone who attended the meeting has the job of looking around for other cohorts and contacting other principal investigators to see whether they would like to participate. There'll be a peer-reviewed paper written up describing this collaborative in the next few months. And then, yeah, probably the biggest task of all is to get some funding to fund this collaborative and bring these cohorts together. So a big thanks to Gabrielle Murphy from the Royal Free, who sort of pretty much coordinated this meeting, which was funded by the Sue Esterman Fund. And we had some very useful information from Caroline Sabin, who runs the UK Sheet, which is an HIV collaborative, cohort collaborative, and Paul Burton on issues of managing large amounts of data, and the UK CMRC, because this sort of came about really at the last CMRC meeting. So, thank you.
Great, thank you, Simon. I'm rather concerned that 2 out of 3 participants in today's session have both vomited in my presence. And I'm pleased to say, I'm assuming that Dr Strachan hasn't vomited in my presence.
Yes.
So, and thank you, Simon, for catching us up on time. So, as I said, we'll have everybody up for questions all together at the end.
Good morning. Thank you very much for the opportunity to speak here today. My name is Caroline Strachan, and far from being just an oncologist, I'm afraid I'm just a surgeon, so even worse, and very much new to this field as well. I'm a surgical research registrar in Leeds, and I'm here to talk to you today about some research we've been doing comparing the lymphocyte phenotype in chronic fatigue patients to those with breast cancer related related fatigue. Just in an endeavour to assess what fatigue really looks like to the immune system. There we go. Firstly, I would like to thank ME Research UK for their support in funding this research. So firstly, I'd like to run through some background to this by taking you through some key findings in the immunological research in CFS ME, before going on to introduce you to what we've been doing and what we've found of significance thus far. I'd like to bear in mind that this is preliminary data in an ongoing project, and also like to direct to our poster which we've been showing throughout the conference, which highlights some additional data. Immunity in chronic fatigue, as we've been hearing, has been widely researched, but no consistent findings have led to the identification of biomarkers of fatigue, or indeed uniform irregularities in this patient cohort. We are specifically interested in lymphocytes, B cells in particular, and the role that they may play in the regulation of disease processes such as fatigue and cancer, specifically breast cancer. A number of patients have examined the role of lymphocytes, in CFS and ME with completely conflicting outcomes. So T cell subsets, NK cells, B lymphocytes have all been implicated in the pathogenesis. Decreases and increases in CD4 T cells, for example, have been suggested, along with increases and decreases in B cell subsets, indicating to me that this current literature is contradictory and, to me, quite confusing. A number of studies have concentrated on cytokine networks in the etiology of chronic fatigue, including pro-inflammatory driven cytokine sickness behaviours akin to autoimmune diseases and anti-inflammatory driven responses to exertion. Increases in anti-inflammatory cytokine IL-10 and interferon gamma have been demonstrated in chronic fatigue patients, including reports of increased IL-10 in the post-exercise period. However, where these cytokine cascades are coming from and what drives them has not fully been elucidated. IL-10 is a potent deactivator or anti-inflammatory cytokine, and it's crucial to this research. In this context, it is the main effector function of a subset of cytokine-producing regulatory B cells, or B-regs as we'll call them, which have recently been described and are the focus of research in different fields such as autoimmunity, transplant, and are just beginning to take off in cancer. No phenotype of B-regs has been identified, so we know what they do in terms of IL-10 production, or IL-10 and TNF-alpha production, but just we don't know exactly what they look like or where they're from. Although it's thought that a number of B cells may be able to exert regulatory function by producing these cytokines, so IL-10 and TNF-alpha, for example. Seminal works by Mowry have postulated the transitional B cell pool as the hub for B-reg function in various autoimmune diseases. And work in our own laboratory concludes B-regs from the transitional pool are crucial in regulating graft function in following renal transplant. Work from Bradley's group analysed B-cell subsets by flow cytometry in 33 patients with CFS-ME and found statistically significant increases in the transitional B-cell populations, also in the naive B-cell populations, and interestingly reduced plasmablast populations. So what does this all mean? So firstly, and very briefly, B cells are divided into subpopulations based on their level of maturity or antigen exposure. So following early development in the bone marrow where they develop their B cell receptor, they migrate into the peripheral blood on their way to secondary lymphoid organs as transitional B cells. And you need to remember these B cells, these type of B cells, they're important. So they express CD10 and high levels of CD24 and CD38. So in peripheral blood, they differentiate further into antigen-naive but mature B cells, where they lose their CD10 expression, have lower CD24 and 38, they're CD27 negative and IgD, IgM positive. So following exposure to antigen in the secondary lymphoid tissue, they undergo T helper cell dependent activation and they gain expression of CD27, and then they differentiate further into memory or plasma cell B cells. Fine. As we've been hearing this morning, the most significant progress with B cell research into chronic fatigue has come from the observation by Professor Fluge and Mella in 2009 that fatigue symptoms improve following B cell depletion therapy with rituximab, suggesting that modifying B cell number and function is crucial in the etiology of fatigue. Now, other patient cohorts also report symptoms of chronic fatigue, for example, patients with autoimmune pathologies, and pertinent to this research, cancer patients. Cancer-related fatigue is an increasingly recognised phenomenon following diagnosis and treatment of malignancy. Defined by ASCO, which is the American Society of Clinical Oncology last year, cancer-related fatigue is a distressing, persistent sense of physical, emotional and cognitive exhaustion related to cancer that is not proportional to activity. Now, fatigue is almost universal in the treatment phase for cancer, but chronicity of fatigue symptoms in this cohort are reported in up to a third of patients following cancer 10 years after their diagnosis, and has even been linked to shorter survival in breast cancer patients. Again, this might sound familiar, but immunity has been widely researched in cancer-related fatigue, and again, no uniform immunophenotype has been elucidated, largely due to the paucity of data and inconsistencies in the literature on the diagnosis and the etiology. Pro-inflammatory cytokines such as IL-6 and IL-1 receptor have been put forward as causative agents. C-reactive protein and lymphocyte dysfunction are also much reported to be associated with symptoms in cancer-related fatigue. So here we will discuss the differences and the similarities between the immunophenotype of patients with newly diagnosed chronic fatigue syndrome and those with breast cancer. We'll then analyse the immunophenotype differences of breast cancer patients pre- and post-chemotherapy with and without fatigue to try and provide a comparative analysis of what we think fatigue looks like. In addition, we'll try and narrow the diagnosis of chronic fatigue based on Children SF36 scores to identify phenotype differences between cohorts with severe symptoms. So we think that this is a novel approach to CFS immunological research. By narrowing the diagnosis and comparing the phenotype to those who develop fatigue, started out without it, in these two patient groups, we'll hopefully identify the changes responsible for the development of this illness. Our inclusion criteria are therefore quite strict. For our chronic fatigue cohort, they needed to describe a preceding viral illness. The duration of their fatigue must have been at least 6 months. We did not include patients with previous autoimmune, malignant, rheumatological, chronic pain or psychiatric illnesses, or any previous or current immune modulating medicines. Our breast cancer cohorts were to receive adjuvant chemotherapy, and again they were to have no backgrounds of these previous illnesses. So the study design is shown here very briefly. The breast cancer patients were recruited 2 weeks following their surgery and roughly 2 weeks before their chemotherapy. At this point they gave a blood sample and completed a group of questionnaires. The chronic fatigue patients again were recruited at diagnosis prior to their CBT, which they all received, and then they repeated this group of questionnaires and blood sample following their treatment, approximately 6 months. We've recruited 7 control patients throughout, and again they gave just 1 blood sample and are yet to complete the questionnaires. The questionnaires contained Chalder, SF36, HADS, Epworth sleepiness, self-efficacy, visual analog pain rating scale, and the EQ5D. These were all repeated post-treatment. Now, as comparative analysis between the 2 cohorts was the aim of the questionnaires, they were all uniform between the 2 cohorts. This meant that validated questionnaires for the assessment of cancer-related fatigue, such as the EORTC breast module, for example, was not used. Right, I do apologise for those who are very familiar with these techniques, but I'll just run through a background to our methodology for those unfamiliar. So we use flow cytometry to look at a population of lymphocytes from peripheral blood on a cell-by-cell basis to analyse what the cell looks like on the outside and on the inside. So very briefly, cells are stained with surface markers attached to fluorochromes, passed through a liquid through a laser, which then prompts the scatter of light of these different fluorochrome wavelengths, which are then detected and processed by detectors, translating that into an electronic signal and resulting in a dot plot such as this. So it's dead simple, took me ages to get used to that. Right, so here we identify lymphocytes based on how large and how granular they are, so forward and side scatter. So we can then draw around these population of lymphocytes and only analyse these, so we forget all about the rest of what we see on this dot plot. Each dot plot represents a cell, so each dot on the plot represents a cell. So from the lymphocytes, we then look at what's on the lymphocytes. So we want to highlight our CD19 B cells, for example. And from that, we can then divide the B cells up into what they look like again on their surface. So our transitional cells, as you remember, have CD10, CD38, and they'll also have CD24 expressed very highly as well. And our non-transitional cells we've divided into our memory and our naive populations based on their expression of CD27 and CD38. So, with our peripheral blood samples, we analyse lymphocyte subsets by staining the blood with cell surface antibodies to represent T, B and NK cells and their respective subsets. So for the B cell panel, which is what we're going to talk about, we wanted to analyse naive, transitional, switched and non-switched memory and plasma cells. The main one really, to remember here is the transitional cell population. Identification of intracellular cytokines is a little more involved. So B cells are isolated from peripheral blood. They're stimulated for 48 hours to produce cytokines, followed by stimulation with an antibody panel to identify the relative production of IL-10 and TNF-alpha from the various B cell subsets, which are here. And again, so we're looking at our transitional memory and non-transitional subsets. So, to date we've recruited 21 chronic fatigue syndrome patients and 43 breast cancer patients. Just over 16 breast cancer patients have completed the study following their chemotherapy, so they're 6 months post-chemotherapy and a year post their cancer diagnosis. And we'll discuss their post-treatment analysis. To date we've just recruited 7 controls, and post-CBT CFS patients, we've just got 1 so far, so we won't discuss their post-treatment analysis. So, have we found anything significant? Well, firstly, we demonstrate that our chronic fatigue syndrome patients are significantly more fatigued based on SF36 and Chalder scores than our breast cancer patients. Looking specifically at B cell subsets, our naive, switched, non-switched, transitional and plasma cell subsets pre-treatment are all within normal reference ranges and not statistically different between the cohorts. But what about differences in B-cell intracellular cytokines, so anti-inflammatory IL-10 and pro-inflammatory TNF-alpha? Well, we noticed that transitional B cells produce less IL-10 than, in CFS patients than breast cancer or controls. And you can see that here, and that's statistically significant. This did not, however, correlate to an increase in pro-inflammatory TNF-alpha, so that's not significant, suggesting that the balance of pro to anti-inflammatory TNF-alpha and IL-10 may be different in CFS. What about analysing the severity of fatigue then against the transitional B-cell population? Whilst the numbers are small, there is a strong correlation here between transitional B cells and SF36 scores in CFS patients. So the poorer the physical function, the lower the number of transitional B cells. This correlation is also seen in T1 cells, which is the population of transitional B cells expressing very, very high CD30s on their cell surface. No correlation, however, is seen with Chalder scores in transitional B cells, but a strong correlation with naive B cells in Chalder scores is seen, where the higher the number, of naive cells is correlated with the increased Chalder score. So whilst this inter-cohort correlation is novel and does highlight some interesting focus for research, it does not yet address this comparative analysis that we promised you with other fatigued cohorts. So how does this compare to breast cancer patients pre and post chemotherapy? So firstly, let's analyse what chemotherapy does to the immune system and whether this translates to the development of fatigue. So as we can see from our Chalder and SF36 scores, following chemotherapy, patients are increasingly fatigued, but physical function is not statistically diminished. Lymphocyte populations following chemotherapy are profoundly altered. T and B cell subsets change quite profoundly in their morphology. There are less total T cells, but interestingly, the total number of B cells is not different. Now, this is about 6 months following chemotherapy. Chemotherapy will have depleted B cells significantly, and we have shown that previously. So what we're seeing here in the total numbers, which are not different, is a repopulating B cell pool. With that in mind, we see a significant decrease in the memory B lymphocyte populations and an overall increase in our naive and transitional B cell subsets, with the transitional B cell increasing from 8.9% of total B cells to 19.3%, representing probably the repopulation of our B cells.
Are you finishing? So you're out of time.
Oh, sorry. Almost. So, when we analysed the effects of chemotherapy on regulatory B cell activity, we saw a fall in transitional B cell pro-inflammatory TNF-alpha. This is not reflected by a change in anti-inflammatory IL-10. So I'll just skip through the next one. This is one of the most important slides. So, following chemotherapy, we saw a strong correlation with transitional B cell numbers and SF36 scores, again reflecting the poorer physical function, the lower number of transitional B cells. This correlated with IL-10 production following chemotherapy with fatigue scores in the Chalder fatigue. Fine. So, concluding then, what does this actually mean? So, in the CFS cohort, lower physical function correlates with fewer transitional B cells. This is also seen post-chemotherapy in patients with poor physical function. There's a negative correlation with transitional IL-10 and Chalder scores following chemo, and as we saw very briefly, a decrease in TNF-alpha production following chemo throughout the B cell subsets. So, whilst this work is preliminary and very much ongoing, it does point to the transitional B cell pool where regulatory B cell activity has been demonstrated and proposed as a hub for B-regs is key to unlocking the immunophenotype, we think, in chronic fatigue. So, sorry for running over. We'd like to thank firstly our patients and ME research team.
Fantastic, clearly not just a surgeon. Right, so can we have